Welcome to Pomegranate Health. I'm Mick Cavazzini for the Royal Australasian College of Physicians, and this is the second episode of our IMJ On-Air series. In the November issue of the Internal Medicine Journal, we have a clinical perspectives review dealing with a scenario you've probably already encountered: patients who are taking complementary or alternative medicines, whose benefit you're not too sure about. About 2/3 of Australians use CAMs, but only around half of these people will mention it to their doctor. This can complicate management of patients in palliative care particularly, as they're less resilient to the outcomes of drug interactions. To discuss this, I've got the article's authors with me in person and online, but I'll leave the introductions to the journal's clinical pharmacology section editor, Jonathan Brett, in whose office we're sitting at St Vincent's Hospital, Sydney. John, can you tell us what you do, as well as volunteering your time to the college publication?
Thanks, Mick. So I'm a clinical pharmacologist, toxicologist and addiction specialist, and I'm also a senior research fellow at University of New South Wales, and we're sat here in the bowels of St Vincent's Hospital in the clinical pharmacology department in my relatively small office, but it's a great pleasure to be with you today. And thank you, Jenny, for coming in person. Could I ask you to introduce yourself?
I'm Jennifer Martin. I'm a general physician and a clinical pharmacologist, and have a role with the college in terms of training advanced trainees in general medicine and pharmacology to be specialists. And I'm really delighted that Dr. Joe Patel, who's a palliative care specialist, came and trained with us in clinical pharmacology for a year. And we realised at that time, I think, that there was quite a lot of overlap with drugs and drug development and the clinical pharmacology area.
Thanks, Jenny. And Joe, would you like to add to that?
As Jenny said, I'm a palliative care specialist up in Newcastle in New South Wales, and I'm also a dual trainee and an advanced trainee in clinical pharmacology, and I've worked with Jen before.
Fabulous. So I'll launch straight into the paper, which I read with great interest. Just to get a sense of perspective, in your clinical practice, how often are you having conversations about complementary alternative medicines?
In my clinical practice, doing palliative care regularly, so every patient that I would see, I would have the time to do a medication review and ask patients what medications they're taking, and that would include over-the-counter and otherwise source medications. Complementary and alternative medicines traditionally are thought of medications that not necessarily prescribed by a physician, and that maybe have limited evidence base, but patients use either to augment and help with their symptoms or to help manage an underlying diagnosis. And that can either be alongside traditional prescribed medications or sometimes instead of.
Is it something that comes up quite frequently in your practice? People ask you about this, or does it often just come up when you ask them?
To be honest, even when you do ask them, often it doesn't come up because people often don't recognise that formulation they're getting from a health food store that we would class as a complementary or alternative medicine, people think of as a dietary supplement or otherwise. So sometimes even doing what we think is a comprehensive medication history, we can still miss these things that is what we're interested in. I would say that frequently patients who I see, by the nature of being in palliative care, people have complex symptoms and have usually tried several things, prescribed or non-prescribed, before I get to meet them. And they may have self-discontinued. There's a cost associated with these medications. They may have self-discontinued if they've not found that they're helpful, or they may still be taking them. The thing that I probably get approached about most regularly in this space would be cannabinoids, and I think a lot of my colleagues would say the same.
Thanks. I'm glad you brought that up because you gave in the paper some great examples of complementary medicines, including capsaicin, ointments, evening primrose and melatonin. But I think it's interesting to focus in on cannabinoids. And I am aware that there have been previous podcasts on this, but I'll go over to Jenny. What do you think are the sort of major issues with cannabinoids in the palliative care space at the moment?
I think the field's moved on since we last spoke on this a few years ago. I think there's a lot more access for patients to getting cannabinoids, and they can access those through the special access scheme and either through their own doctor, or if their own doctor is unwilling to prescribe, often these patients are actually sourcing external help in terms of the cannabis clinics, which are often an online. So patients are people have got more access to cannabinoids, but I think there's a lot less regulation around what's happening with those cannabinoids and just the follow-up and the clinical care aspects of the patient. So just as an example, we had a patient probably several months ago now that rang our research centre because they had been given a cannabinoid for symptoms in a palliative care setting, and that patient was getting quite nasty serotonergic symptoms, but didn't actually know the name of the prescriber or where they could get help. And because they hadn't had them prescribed through their GP, they didn't feel comfortable going back to their GP to explain this problem. But I guess that highlighted for me something that we've seen a lot of and heard a bit about, which is that there's a lot of fragmentation of care and easy access to these products, but these patients are actually not all that well. And when they get into problems, it's very difficult for them to get the medical help that they need in a timely manner.
That's a pretty unfortunate situation there. Just to take a step back and remind listeners what we're talking about when we talk about cannabinoids, because it's not a simple area. Would you mind just sort of giving an overview?
Yeah, that's a good point, actually. People think that it's just one thing, but as we know, the plant's got a number of different chemicals, and there are two that are commonly used in the palliative care setting. That's THC, or delta-9 THC. That's the active component that people used to smoke recreationally to obtain benefits from. It often gives people dissociative, some almost psychotic and psychotic sometimes symptoms, and I think people feel that might be helpful sometimes if they want dissociation in an end-of-life setting. Then there's cannabidiol, which is the second major component of the cannabis plant, and although that's said to be non-psychoactive, I'm not actually sure where that wording came from, because we know that people feel quite sedated. They often use it for sleep. People feel that they get relief from anxiety symptoms with cannabidiol. So it's really those two components of the plant which are the major constituents. I think the thing is that people are often not all that aware of what the two different components are when they're buying it. And they often might change the combination and the relative proportions of those two compounds in the product that they're seeking. So they might, for example, they might source one combination somewhere that's got a lot of THC and then source it at the cannabis clinic, which has got a different amount, and then they're getting into all sorts of problems with their other medications. So I think it's just that whole thing of awareness for patients, not really sure what they're taking. And then if they go to smoking, which we've often seen, particularly as their symptoms worsen towards the end of life, is they'll start off taking a medical product. It might be prescribed appropriately, and then they'll smoke as well to get additional benefit from the cannabis. And then we're getting a whole lot of other extracts from that joint, essentially. So the problems, I think, are just all the problems that we always have with medicines around the education, around the oversight and the governance of medicines, and then that whole thing of bringing in clinical care so that the patient's doctor can actually identify that there's a problem here or the drug interactions that are to do with a part of the cannabis. So I think that's probably more the situation we're seeing now, whereas in the past, I think the issue was that patients actually couldn't get access to a cannabinoid at all, even if it was felt by a medical practitioner that they might benefit.
Since the rescheduling, the cat's really out of the bag, I think, isn't it?
I think, some in the community think that the rescheduling has been good because it has enabled, a commercial business to develop in terms of the cannabis clinics, and it has made it easier for people with long-standing chronic pain and other issues to access a quality cannabinoid as opposed to smoking something that might have a lot of other chemicals in it. So I think that part of the community might feel overjoyed by a change in the scheduling from Schedule 9 to 8. But I think from a medical perspective, we've seen a lot of harms, and it's also made it quite difficult from a clinical research perspective to either get funding for research or also to get patients to enrol in trials. So I think it has been difficult from that perspective because we've actually lost a really good opportunity to get quality data, both in an observational setting but also in a randomised controlled setting, to find out how to use these cannabinoids optimally. And because of that, we're now left with this rather veterinarian situation where patients, the onus is on them to ask a practitioner to prescribe something that they think might be beneficial, but they're doing that without all their other medical notes and clinical care and just that relationship with the doctor that would often change, I think, the way drugs were used in that setting.
So generation of new evidence has become a real challenge.
Yeah, it's a shame, really.
Just in terms of evidence, Joanne, you noted in the paper that the number needed to treat for post-hepatic neuralgia for pregabalin was 4 and for cannabis-based products is 20. But in terms of palliative care indications, do you have a sense of what they are and what the level of evidence is for cannabis-based products for those things?
The evidence base is poor, I suppose. It's growing all the time. There's a lot of people doing a lot of work in it, but as Jenny said, it's really hard to recruit patients to any large study in palliative care. By nature, the patients we look after in palliative care are usually excluded from most traditional clinical trials. They're often not always elderly. They're often poor functional status on multiple other medications. It's hard to control for those confounders. So the evidence base is lacking, but I don't know that we're ever going to achieve hugely high quality, highly powered studies in the palliative care space. And that's the true of a lot of the medicines we use, to be honest, in palliative care because of all those challenges. And so we do use also a sense of, there's an anecdotal bias to all of our prescribing probably in terms of what we've seen work and what we haven't. In terms of the question of how do I think it compares to the other agents as an analgesic, there's no perfect analgesic, particularly for neuropathic pain and poorly opioid responsive pains. I don't see that cannabis or cannabinoids are any better than any of the other things that we prescribe. I think that the efficacy as an analgesic, in my practice, what I've seen supports what the data shows, which that I think it's less efficacious than other things that we've tried and can have harms. But that doesn't discount the fact that some patients have tried everything, and occasionally it does have a big benefit for a patient, whether that's part of the psychosocial context and a placebo response, or whether that's just that person's biochemical makeup that they respond well to the cannabinoids. And you don't want to exclude patients trying or having an attempt if it's really important to them, because that can also harm a therapeutic relationship if they really want to try something.
Can I just chime in there to zero in on the indications that, or the uses that are most common? So we know that there are TGA listed products, Epidiolex, which is a liquid cannabidiol, and Sativex, which is a mucosal spray. Yeah. There are indications for childhood epilepsy or multiple sclerosis spasms. In the palliative setting, is it pain that they're most often coming to you about, and is it hard to get that prescription, or would many clinicians be inclined to give that prescription off-label?
Yeah. In practice, I think it isn't just pain. I think people have a sense that cannabis or cannabinoids are a one-size-fits-all kind of medicine, and that whole sense of general well-being, improvement in nausea, improvement in appetite, improvement in sleep. There's some perception that there's no side effects, I think, among the general public, and I think there's a perception that if they can use cannabis, it might replace some of their other medications, which, although they also have side effects, are probably doing a better job of improving the pain. So I think in my practice, what I've seen, I think it gets prescribed probably more for appetite and well-being, possibly nausea, rather than for pain. There are certainly prescribers of cannabinoids amongst us, but it's very dependent on the patient. It's not really a standard approach because it doesn't fit in with the evidence. In terms of off-label use, like in the palliative space, a lot of the medications we use aren't indications they're PBS listed for, in terms of antiemetics and things. So I don't think it's necessarily about the PBS and the regulations that puts people off prescribing. I think it's more concern about that benefit-harm ratio with the particular drug.
So there's only 2 products that actually have data that supports a TGA a registration listing, and you've identified those. That's the Sativex oral mucosal spray for spasticity and MS, and then the Epidiolex, which is cannabidiol for rare forms of pediatric epilepsy. But patients can access through the SAS-B scheme, and it was actually set up for patients to be able to get access to off-label drugs, usually as a single drug, not as a class of a drug like the cannabinoids have become. But people can get access through that pathway for any symptom as long as a doctor is willing to write a script for it. And I guess that's another really important point just for this podcast, that if we're thinking about, where was the need, where was the unmet clinical need. I think we all felt that a quality cannabinoid product might relieve symptoms at the end of life. But when we look at the TGA data, we can see that their highest users by far, like almost all of them are scripts actually for chronic pain. And they're actually in a patient group which is aged 18 to 45 and male. So it's a male chronic pain population that's accessing SASB. 18 to 45-year-olds are our most productive people in the workforce. And we've now given these people another chemical that we know has psychoactive effects. And that's a separate issue. I don't really want to go into that so much today, but the TGA data suggests that the people that are accessing it are not necessarily those that the clinicians felt we had an unmet need to fill in the clinical space.
Okay, great, thanks. Actually, sticking with regulation, because I think this is a really interesting topic. Thinking about complementary medicines as a whole, you did talk briefly about how they're registered in the paper. Would you mind just stepping us through that?
Yes, so there's two pathways for registration of a product. There's one which is an AUST, AUSTL, and that's a listed product. And that usually does cover complementary medicines, but you still need a level of safety and safety data for that drug to be considered to be registered with an AUST-L label. And then we have AUST-R, which is the registered medicines. And that's most of the medicines that we would prescribe on a script as a doctor. But I know that with cannabinoids, a lot of the community wanted to push for an AUST-L listing for cannabinoids. But because of the space in which they were used, so vulnerable populations, because of the risk of drug interactions and because of a whole lot of other issues around efficacy and quality of the product, it was deemed that these would go down the standard evaluation process for a standard medicine, and the TGA expected that these would be used as a medicine.
Actually, I think just following on from a couple of things you just brought up there, I want to pick up on the sort of safety around interactions, but also around purity, excipients, and contaminants. I think that's a really important consideration. What are the requirements for the TGA to test for SASB imported products for cannabis, for example, on those things, purity, excipients, contaminants?
Yes, well, that was a big thing, I think, that people hadn't quite thought about initially. People thought that, we've been growing in our backyard for years, so how unsafe can it be? But I think actually when people started testing it, they realised that, particularly in the area that Joe and I work in Newcastle, there's a lot of heavy metal in the cannabis, and in some parts of the world, the cannabis plant is used to sort of clean up the soil after mining. So very high levels of lead and arsenic and other compounds. So the TGA did bring in a standard called TGO 93. So TGO 93 regulates a lot of that stuff around quality of the product for cannabinoids. And essentially, if you're importing it, all imports have to meet the standards, which tell you, that you've got no fungus, there's no insecticide, there's no heavy metals on it, and what sort of percentage of the plant is THC or CBD. We're not really using so much of the imported dry product anymore because I think it is difficult to standardise it. And look, we just as an aside, we went down that pathway to start with, doing vaporised studies with dried product because we couldn't actually get synthetic extracts or other extracts. And we were finding that the composition of the product at the start of the trial was actually quite different to the end. And I think if you're trying to help get these products registered by the TGA and the product's actually changing during the trial, that's not great. But the TGO standard doesn't really look at the shelf life and stability so much, so that issue could still be there, and researchers have to do their own work in that area, but it does just check that it's pretty safe and all of those toxins, the aflatoxins and things we were worried about are not present. And it's actually fascinating because I sometimes get emails or phone calls from someone out in the public who says something like, "Hey, Jen, you're the researcher up in HMRI doing all this research, and I've gone and I've got the script and I've gone and spent all this money and I don't think this is the real deal. So I'm wondering if I can just drop it off in the hospital and get you to test it for me." So I don't know how many of those we've had, maybe a couple of dozen of people just ringing up our research centre and offering to drop their product off. The problem being that obviously they're dropping off product that has a whole lot of legal and security issues in a hospital, and I'm a medical practitioner, so there's a whole lot of duties of care when I receive a product and then find out it's not good in terms of my then requirements to manage that patient. So it has been a bit fraught, but we just give the advice that for people to be very careful. And there is a list of quality products that are well documented and people have used in clinical trials, and they're essentially a pharmaceuticalised their product. We have also set up a drug information service, which is for the state, but run at the Hunter. And that's, again, we can say to the patients, please just ask your doctor to ring our service, and we can give them information about a quality product, because not all of that stuff that's imported is actually quality.
That sort of leads on to a question around interactions. So, Jo, I might ask you about this. I think, cannabis products are a good exemplar of, one, how important it is to ask about whether people are taking anything else, and two, about potential drug-drug interactions. Could you give us an examples from your clinical experience about that?
Yeah. I suppose I can think of a couple of examples, and it sort of highlights the differences in the PAL care space as well. So we do supportive care. So I see a lot of patients who are on palliative chemotherapy with an intent that's going to prolong their life, and we see them in a supportive care space. And we see patients who are on cannabis, and it could either be prescribed or it could be sourced themselves, who are also on immunotherapy with intent of life prolonging. And we know that there is a drug-drug interaction that's been demonstrated in studies between immunotherapy and cannabis, and that cannabinoids may actually impair overall survival and shorten time to tumour progression. And often that's something that people are unaware of. So part of my history taking when I ask about cannabis is I highlight the reason why I'm asking is because it can interact with other medications. And I just encourage patients to talk to their oncologists about that to get the best advice that they can have. I suppose with anything we prescribe, because it's a risk-benefit ratio, isn't it, for any drug, for any indication. And in the other space of palliative care, where it is very end of life and it's purely symptom control that we're looking at, and there's not active anti-cancer medications or whatever other malignant disease it may be, the aim is to make people feel better each day. And that's where my job's quite easy, because I don't have to wait for scans to know whether treatment's working. I can just ask someone whether they're feeling better. But often they're not feeling better after they start a new drug, and that could be anything. But with cannabinoids or other complementary or alternative medicines, there's interactions with other medications they might be taking. So if they're on, for example, an SSRI, a serotonin reuptake inhibitor for depression or anxiety, and they start a cannabinoid, there can be an interaction there which may worsen their symptoms. It could precipitate nausea, it could make them feel anxious. So there's just two examples of different spaces where the reason we ask, and explaining to patients why we're asking.
Thanks, Jo. So my understanding is that with CBD in particular, cannabidiol, you have both pharmacokinetic and pharmacodynamic interactions. So what is perceived as a fairly benign treatment can actually have fairly clinically significant interactions. Would either of you like to step us through what the P450 interactions might be and what the potential pharmacodynamic interactions are?
Yeah, so with CBD in particular, I suppose the somnolence, the anti-anxiety, all of those things, if someone's also on, for example, opioids or benzodiazepines to help manage their anxiety or make them sleep, it can actually be really quite sedating. And it just potentiates those effects.
And often people in palliative care are already on a number of sedatives.
Yeah, and it also may be that the CBD may be the long-term medication that patient's been on, but then we decide to add a sedative as a patient's getting closer to the end of life, and the risk-benefit ratio means that we think they may benefit from that. But just to be aware that maybe we need to use a lower dose, because if that patient's already stable on CBD, you want to be cautious in case you're going to potentiate those effects. Jen, do you want to talk about the pharmacokinetic interactions?
Yep. So cannabidiol, it's a really fatty drug because it comes from a plant. And so we can't excrete fatty drugs without making them water soluble. So you kind of got an alarm bell ringing already that you're going to have to metabolize this, and you're going to have to sort of add lots of things in the liver to make it water soluble. And I guess that means that there will be a lot of drug interactions, and cannabidiol does get broken down through the P450 system, but it also acts as an inhibitor, so it blocks the enzyme that breaks drugs down as well. So, and probably a pan-enzyme inhibitor, but it probably does have particular effect on drugs that are broken down through the CYP2D6 pathway, which is the one that breaks down most of our neurology and psychoactive drugs. So a lot of our antidepressants are broken down through that pathway, and antipsychotic drugs, and it probably inhibits CYP3A4, which is essentially the enzyme that breaks down the rest. So really, if you're on cannabidiol, levels of other drugs that you're on that are broken down through the P450 system will become quite high. And so, again, Joe's already given a really good point with the benzodiazepines, that actually, if you need to use them, if the cannabidiol is not providing the sedation that you need and you're wanting to use a benzodiazepine, you can use it, but just go very carefully with the dose and just start on a very small dose, because I think one of the studies with Dravet syndrome, the pediatric epilepsy syndromes, the children were given cannabidiol. They were quite sleepy, and everyone thought it was probably the cannabidiol, except the levels of the clobazam, which is a benzodiazepine, were very, very high, and in subsequent studies between 5 to 8-fold higher. So there's still an uncomfortableness, I guess, amongst the epilepsy community, that maybe the benefit of cannabidiol in that setting was just because the benzodiazepine level was so high, and there's quite a lot of literature around that. My colleagues say maybe it doesn't really matter what the mechanism was, because you've actually reduced the seizures, but I think that you might be able to get away with a lot lower dose of those other drugs if you're starting with cannabidiol. And coming back to that earlier case that we discussed, where the patient from the cannabis clinic rang our research centre, they were actually on a serotonergic antidepressant and were getting quite significant serotonergic symptoms. And I can't actually remember the dose, but I recall it not being that high. It's not at a dose that you would usually expect serotonergic symptoms just from that SSRI alone. So I think really it is a cause for concern, and I think just go slow, go low, go slow.
Yeah, interesting. So I imagine it's often quite challenging to unpick symptoms at the end of life, and we want to make damn sure that we're not contributing to that.
I mean, if we can measure levels, that's really helpful, because we have a research centre that's aligned to the back of our campus. We can measure concentrations, and so we can see that, particularly in our clinical trials, that the levels do correlate with symptoms. But I think you can tell just clinically from the symptoms that people have. And probably, as the palliative care fraternity tell us, and Joe's already outlined, that if you ask someone every day and they tell you how they're feeling and you actually listen, then you can probably do that without measuring levels. And that whole mantra of actually, if you take the history properly, so go back and retake the history and ask the things that weren't taken initially. And the medications, I think, are often done very quickly. There's sometimes written in the margin of a written report. No one has written when the drugs are started, when they're stopped, what happened last time they're in hospital, when they stopped and started their CAM medicine as well. Yeah, I would just support that.
We've got a question for Joanne, actually. Back in episode 33, last time I spoke to Jenny, I also interviewed Professor Mira Agar, who's a palliative care specialist doing trials of cannabinoids for cachexia. And she had an interesting point that while often patients and families at the end of life are willing to try anything as a sort of Hail Mary intervention for their symptoms, she took a much more conservative approach, because these people are so frail and so vulnerable to dosage errors and interactions. So maybe, Joe, do you want to talk from your experience about the frailties of these patients and how unpredictable outcomes might be?
Patients at the end of life are very vulnerable. Just thinking of it from a pharmacology point of view, there's often rapid weight loss. They're often not eating, and there's big changes in their diet and their oral intake of water. All of those things impact all of the drugs that they're taking and their general sense of well-being. And I feel that they're just a lot more vulnerable to side effects. And often the side effects of whatever CAM it is, often is the symptom you're trying to treat. Like, people get debilitated by nausea occasionally. And any medication you look at, you go on MIMS or AMH, any medication has nausea listed as a side effect. I think if you talk through that with patients, if they come to you with concerns or questions about a CAM, is being open and honest with them that there's a good chance this might make it actually worse. And unless we're in an evidence base that we know it's going to be better, it is a trial and error. And being open to trying things if patients want to, but having a low threshold to stop them if we think it actually might be making them worse because of their frailty, the changes in their pharmacodynamics and pharmacokinetics towards the end of life.
It's sort of reminiscent of opioids in some ways, isn't it? The sort of, we talk about universal precautions with opioids, having only prescribing if it's necessary, having a treatment goal, and having a sort of a de-escalation strategy. So I think it's probably even more relevant with the sheer number of medicines people might be on at the end of life. But I just wanted to sort of follow on to, I think, what's probably one of the most important interactions, which is the doctor-patient interaction. And Joe, just in terms of the conversations you're having with patients, could you tell us the kind of things that come up and some of the challenges, particularly around complementary medicines?
Yeah, absolutely. I'm really fortunate. I get a lot of time with my patients, and I know that my general medicine colleagues, and especially my general practitioner colleagues, don't get the privilege of the time I have with patients. But people, they just want to be heard. And if they've had ideas or suggestions from people in their lives about things that might work or make them feel better, or, the huge holy grail of it might cure my cancer, they want to talk about it and they want to feel heard, and they don't want to be dismissed or have that dismissed. I just talk to patients the same way I talk to medical students and junior colleagues. If they want to go to that level of evidence, I'm happy to sit down and break it down with them. These are the things that this medication might be good for. These are the harms we know it might have. These are the interactions. And just being honest that all the other things that I'm prescribing, the opioids or the pregabalin or whatever it may be, there's risks and benefits to those too. I just understand them a bit better because I'm a bit more familiar with them and we've got a higher evidence base for them. If it's really essential to the therapeutic relationship, then I'll try and support it, but just put in safe parameters and make them feel comfortable with coming to me or their GP with concerns. A lot of people, especially if they've gone to a prescriber or gone online to buy their medications, may feel like they've been dishonest or they don't want to impair the doctor-therapeutic relationship as well. So I think you just got to be open and honest with people and just be kind and compassionate that they're in a space where they're also trying to do their best, and we've just got a little bit more knowledge to guide them, hopefully.
Yeah, absolutely. Mick, was there anything else you wanted to ask?
Yeah, I might just throw one grenade in there before we go. Jenny and Joanne, you wrote in the paper that the annual Australian private expenditure on complementary and alternative medicines is $4 billion. And so this prompted me to look up from a federal government report from several years ago that the gross out-of-pocket spend on listed pharmaceuticals was only $1.7 billion. So what do we make of that, and how can you frame that for patients, where to put their bang for buck, where to put their value for money? Yeah.
So I think it's a fascinating question too, because often, like I used to sit on PBAC, and quite a lot of issues would come into the media on the day that PBAC actually was meeting, and there'd be a patient that would be out of pocket if the PBAC didn't list this drug. And it, obviously hurts a lot to think that someone can't actually get medicine that might benefit them if a public subsidy is not provided. But then on the other hand, I actually am always surprised at how much people will spend on, for example, cannabinoids and medication that's not funded. It is an interesting psychological kind of dichotomy, isn't it? And maybe it's that there's an entitlement. Maybe we feel that government should pay for all of our medicines costs. And I think that's what we've grown up with. That's what we expect. But then it's interesting that people do seem to have a lot of funding, not always, but in some cases to actually pay for that out of pocket. But I guess the other thing is that, as I said before, drugs are not listed or not funded on the PBS unless there's enough evidence to know that an investment by the taxpayer in this drug will buy a health outcome for the country that is a good investment. So if it's not listed, most of the time it's because it's not perceived by that committee to be a good investment in the health outcomes of the country.
It's just interesting as humans and as a society. I think the things that we know work to prevent cancer or to keep us well or to treat pain are good diet and exercise and stuff. And it's a privilege to have the time and the energy to be able to do that. And I think if you can bottle something in a pill and tell somebody, oh, this will have the same effects, this will help your pain, this will replace all that time and energy you'd have to spend otherwise, it's quite appealing to people. And people who maybe don't have the scientific background to balance the evidence, which we're very privileged to have that health literacy. I can understand why the expenditure is so high. It's pretty shocking, but people want to feel well.
Really good points. Medication of distress, certainly a big issue in the community as well. But I think you make a really important point in the paper around sometimes patients come to you skeptical of conventional medicine because it's a big industry. And I think it's a really important point that, it seems like the complementary industry is 4 times as big.
I think that is actually an interesting point as it relates to the cannabinoids as well, because in the study that we are recruiting for still, we have over 100 people recruited around New South Wales at the end of life that are taking different cannabinoids, and we are doing the deep listening that our palliative care colleagues do very well. It's fascinating just talking to people about why they're taking the cannabinoid. And so sometimes we get to the point where people are taking their exogenous cannabinoid, so they're smoking out joints 3 times a day, as well as taking a very small amount of medicinal product. And so I say to them, do you still want to be on this trial, because you're taking tenfold what I'm giving you in a tablet every time you smoke a joint, and your symptoms are still there, and it might be good to withdraw from the trial, and then you can actually access other medicines for your symptoms. And there's certainly a sense of I like being on the trial because they basically get a bottle of stuff that they can take as required. So whenever they feel they're getting a twinge of something, they can take something under the tongue. And I think there's definitely control and being able to manage my symptoms.
Do you think that also might be, we know that part of the placebo response is that psychosocial context of health, and that actually being in the trial, regardless of the medication, might be giving some benefit because of those interactions and that sense of monitoring?
People say that as well, and they definitely like the research staff and the research nurses who contact them, quite frequently. I think you're spot on, Joe, that that's giving people a sense of doing something positive and being in control of their current symptoms and doing something that might make them feel better.
It's interesting. What's coming across to me is, with distressed people, particularly at the end of life, the importance of just a good therapeutic relationship and listening to people and helping them feel supported. But I'm also interested in, you brought up the word placebo. If we're thinking about, complementary medicine that we're pretty happy is safe, but we're not sure is effective, is there an important role for placebo effect in treating that population?
Well, I think there is, but I'm interested to see what Joe thinks on this. I mean, in the actual clinical trials that were done with cannabinoids, like, for example, in the Lennox-Gastaut, the other forms of epilepsy, the Dravet syndrome, the placebo response was incredible. So about up to 40% of people got benefit. They actually got a reduction in seizures, even though they were not taking active drug. Now,
not just people, but children.
Children,
which is surprising.
Absolutely. My understanding is with children, it's often mediated through the parents. And actually, there's emerging evidence of open label placebo. You give people a sugar pill and you say there's nothing active in here, but it might help your symptoms. And it's actually almost as effective as a placebo for some indications. Yeah. So it's really interesting. Joe, did you have anything to add about that?
I think there's a huge placebo effect with any of the medications we use. You could use IV morphine, and the evidence shows that a lot of the response to that is the placebo effect, and it makes complete sense to me. It's that feeling of being safe and someone taking your concern seriously and feeling nurtured and supported. It's just the ethics of the openness about that. So, if someone's taking a medication to help them sleep, whatever that may be, or a supplement, a dietary supplement, because I think this is going to help my immune system, I'm happy to support that as long as I'm being open that I don't think there's scientific evidence to support that. But if it's making you feel better and it's not causing side effects and you can afford it, go for it. I think it all just comes back to that benefit-harm balance. And absolutely, if you think something's causing harm because of a drug interaction or a side effect, then we have an obligation to counsel the patient on that and to stop it. But I think we also need to be open to the fact that just because there's not a scientific basis to benefit doesn't necessarily mean that that patient doesn't feel better on it.
I think that's a good place to finish, that, you know, you've described how even for people taking complementary and alternative medicines, the relationship with their physician is important and can be valuable and can steer them in the right direction. So rather than this being a beat up on cannabinoids or any other CAMs, I think you've just pointed out that there's no reason to treat cannabinoids more lightly than we treat any of the other scary big pharma drugs, like you were saying, John, that, you know, to in the regulation and safety testing. So with that, I want to thank Jenny Martin for coming down to Sydney from Newcastle. Thank you, Joanne, for squeezing us in online. And thank you, Jonathan, for having us in your office and
Pleasure. Thanks for coming.
Conducting a studio interview like a natural. That was a great job, everyone. Thank you.
Yeah, pleasure.
Thank you.
Thanks, Joe.
You can read Jennifer Martin and Joanne Patel's paper in the November issue of the Internal Medicine Journal. It's titled Complementary and Alternative Therapies in the Palliative Setting. Every member of the RACP has access to the IMJ included in their membership. Simply go to racp.edu.au/fellows/resources/journals to find the login page. At our website, I've linked to a few tools that can help you predict what drug interactions are associated with CAMs. These include the Australian Medicines Handbook, the MIMS Drug Interactions Database, the TGA's Medicinal Cannabis Hub, and the About Herbs page from the Memorial Sloan Kettering Cancer Centre. Go to racp.edu.au/podcast and click on the episode you've just listened to find out more. You can also go back to episode 29 of Pomegranate Health, which deals with the pharmacokinetics and dynamics of drug interactions in more detail, with a focus on deprescribing in the elderly. And episode 33 gives a pretty good review of the evidence base for cannabinoids up to January 2018. Don't forget that any time you spend listening to these podcasts, reading associated literature, or attending real-life lectures can contribute to your continuing professional development. And I've provided a quick link at each podcast page that will automatically populate your MyCPD profile for convenience. To make sure you don't miss an episode of IMJ On-Air, look for Pomegranate Health in your podcast browser. Most iPhone users listen via Apple Podcasts, while other popular apps are Spotify, Podcast Addict, Overcast, and Castbox. Or for the late adopters, there's a mailing list where you'll get an email when each new episode is published. That's at the top of the podcast webpage. Pomegranate Health is just one of many online learning resources provided at elearning.racp.edu.au. I want to draw your attention particularly to the Medflix video library, where many of the webinars presented by RACP experts are archived, with new recordings added every month. And if you come across any great content you'd like to share with your colleagues, please submit it to the database by clicking on the link titled The Resourceful Physician. There's something there for every specialty. I'm Mika Kabat-Zini, and this podcast was produced on the land of the Gadigal people of the Eora Nation. I pay respect to the storytellers and the healers who first walked this country.